Welcome, everyone. Thank you for joining us. My name is Robby Wallace. I'm VP of Clinical Implementation for Rainfall Health. I oversee care transformation, clinical compliance, and areas of customer success through the clinical care design. I'm here with my colleague.
Good afternoon, everyone. I'm Marla Merkle, Vice President of Compliance and Care Coordination. So I oversee our internal regulatory compliance and the care coordination team.
Thanks, Marla. So today we're talking about compliance and overall compliance risk hiding in plain sight under team, the team mandate under CMS. And this is specifically talking about gain sharing, data governance, and AI and its play in the role. And to be upfront, this isn't a rainfall pitch. This is more informational. If you're here, we're assuming that you know very well about what team is and the CMS mandate, and that team is mandatory for your hospital. This conversation is mostly going to be about implementation and the parts that are genuinely unsexy about that. But we also see that these are the highest stakes in the game. So, with that said, anything else to add, Marla?
Yeah, you know what? And almost no one is talking about this piece publicly, which is exactly why we wanted to bring in someone who's lived it from both sides.
Exactly. So joining us today is Paul Uhrig. Paul was recently Chief Legal and Digital Health Officer at Bassett Healthcare Network. And before that, correct me, Chief Administrative Officer at SureScripts. Is that right?
That's correct. Yes,
Perfect. And Paul, you also sit on our RAIN advisory committee. Is that true?
that's right. That's right. I've had the pleasure of serving on that. Thanks.
Awesome. Well, we welcome you and we thank you very much for joining us today.
No, great to be here. Thanks for having me.
Perfect. And we're thrilled to have you as part of the discussion. We feel like it's a very vital discussion to have. And before we dig in, I just got to throw out the disclaimer for everyone listening that nothing said today is legal advice in any way. We're here to create a warming and lucrative environment for all, and just really focusing on what you have to offer and just your real world experience overall on the topics.
Great. Thanks.
So, just a little bit of light housekeeping before we get started. So, here's how we're going to lay out today's conversation. We'll start with the framing, which is why compliance and data governance are the unsexy but highest stake part of the team implementation. From there, we'll move to our three buckets. Our first bucket is going to be contractual and gain sharing arrangements. Then we'll move to data governance. Finally, we'll talk about AI. And then again, we're going to close on why this is a real issue, and then Paul will share a real world example from his time at SureScripts.
Thanks, Marla, for that. Paul, you've spent your career at the intersection of healthcare regulation and technology. Be really helpful to know kind of what interests you about compliance and the data side, specifically associated with team.
Yeah. No. Like teams in particular. I mean, for decades we've been talking about how the health system is broken. We've been talking about how we should be doing more than just treating patients when they're sick, but making them healthy or making sure they don't go back into the hospital. And we've been talking about a major problem is misaligned incentives, right? So the Teams program to me is a great step to solve a lot of those problems, right? I mean, obviously the purpose is to make sure patients don't get back into, or there's no readmissions, and the whole program is based upon the alignment of incentives amongst the providers in the care continuum. So I think it's a great program that advances our interests. But with any of these types of programs, there is, as we're going to talk about, the compliance risk, right? Because underlying that, you have to make sure you have the right structures in place. I'm also interested in teams from a data perspective. I've spent a lot of my career in the interoperability space, making sure that health data gets to the right place at the right time for the right purpose. And if health systems are really going to manage the post discharge care, information and access to that information is key. And there's a whole regulatory environment behind that as well. And the issues that we're going to talk about are at times complex, but they're issues that we have faced in prior arrangements as well.
Yeah, definitely. I mean, sensitive topics for some, but ultimately educational, and we're here to kind of spread the news and awareness, right? That's our role today. And with that said, it's helpful to know what compliance conversations are happening internally within the hospital and legal teams, and what conversations they should be having right now, but likely aren't. Do you have any kind of toll on that?
Yeah, I think at a high level, um, the legal and compliance teams really should be engaged early on in these discussions, right? I mean, you don't have to be around that long to know that sometimes going to legal and compliance is not always top on the list of people working within a system. But really, what needs to happen here is the operationalization of these programs and the legal structure really do need to go hand in hand. And so I am a fan of making sure that you get the legal teams and the compliance teams involved early because they need to have a view of what's happening operationally, right? And we need to make sure those operations comply with the various laws, Stark and I Kickback and the Teams program that are in place. So I think very much creating a committee, getting the right people together with, which is your technology people, your finance people, your legal people, population health, if that's the right team, get everybody together early on to really start these discussions is I think key to success.
So I've got a follow up question to that. So when we're talking about gain sharing agreements, can you walk us through what's actually involved when a hospital has a gain sharing arrangement with their downstream providers, as it applies to team? Do you have
Sure.
information?
Gain sharing are just one of the arrangements that, that can be put in place to really manage the care and to, as we talked about earlier, sort of make sure these incentives are all aligned. And these can be pretty complex, right? It's not just simply saying we're going to share the savings. And so what you really got to put in place is the right governance, the right data analytics, the right contracting, and then the payment infrastructure, right, to make sure that you're implementing these and executing these arrangements appropriately. Because the whole intent obviously is when there are incentives payments paid by the government, you want to share those with your downstream providers so that they share in the benefits of managing the care, appropriately. And so, you have to look at, as always, the standard anti-kickback provisions, the fraud and abuse provisions on both the federal as well as the state side, to make sure you're sharing these episodic, financial results appropriately. And so, as I was saying earlier, I think you've got the legal documents, but you got to make sure they work hand in hand with your operational um, um, side of the house, if you will. And so, I think a legal department really needs to be in asking, a number of questions about the arrangements as they go into these programs. One is certainly what's the regulatory authority, right? You always sort of start there. What are you worried about? And again, it's going to be Stark, it's going to be the anti-kickback statute, it's going to be the teams regulation on both federal and state sides. You got to be asking, what is the care redesign objective that you're trying to achieve here, right? Is it efficiency? Is it quality? Is it care coordination? Is it all of these things? Um, and then you got to talk about, compensation and how is that calculated? What's the methodology? How are you documenting the sharing of these payments that you're getting from the government? You always have to make sure that these can't be viewed as rewarding referrals, right? That is, the third rail, if you will, in all of these arrangements. What you really need to be doing is making sure that you're providing the care that's needed. And then finally, you got to make sure you have a written agreement, right? I mean, this is where a lot of people maybe fall down in the sense that they think about it after the fact and put in an agreement after the fact. You really have to have all of this documented in your agreements with your downstream providers before you start the implementation, before you start providing the care or sending the patients to the referral sources. So, these are all things that you need to worry about, including the monitoring and the auditing after the fact, in case the government comes in after the fact to audit what's going on in terms of the gain sharing arrangement.
Absolutely. I think that there's some misconception too in regards to what gain sharing actually is for the, ancillary providers, community network partners in the post-acute care space as well. Something that we want to kind of emphasize in those conversations is really fostering those relationships early and getting those communications kind of underway as quickly as possible as we're kind of approaching these conversations or understanding of what gain sharing is and what those relationships look like.
Right, because in many cases, you probably are developing new financial arrangements, right, where you are going to share the savings or the incentives with these providers, and it has to be on the right criteria if you're going to do this properly.
Yeah, absolutely, ethically, legally, and touching on that too. Where do fraud and abuse safe harbors really come into play? And into your in your mind, what's the biggest misstep you see hospitals making here?
Well, often it is, again, sort of not making sure that the actual operations are reflected in the agreement and vice versa, right? And just making sure you have that coordination. You can't have a perfect agreement if your operations are not aligned with what is supposed to happen here. And again, where this needs to go is compliance, right? In late 2020, early 21, OIG did issue the new safe harbor around CMS sponsored model arrangements, right? So, it's a relatively new in the grand scheme of things, and you just need to make sure you are in strict compliance with those requirements, right? And you need to make sure that it's driving the model that you are involved in. You need to make sure the exchange of value is not to induce the referrals, right? It's often not the case, but you got to make sure you can't be construed for that. You can't limit services. The point here is provide the best care, not limit services or provide medically unnecessary services either. And again, all of this needs to be in that writing that you need in place before you start providing the care and referring the patients out.
Yeah. Yeah, no, that makes a lot of sense. We've been touching on a lot of things here, and I really want to highlight the importance of the data governance piece that you mentioned, because as episodes span both in the acute care space, the post-acute care space, and within other settings. What do you think, or what should hospitals really focus on in areas of their compliance teams, and what should they be asking? What kind of questions should they be asking around data specifically and how it's used?
Well, I think that, the first question is always who you're sharing data with, right? And when you're sharing data with other clinicians, with other providers, there are long-standing frameworks by which that occurs today, right? Whether it's TEFCA, the Trusted Exchange Framework and Common Agreement, whether it's Epic Care Everywhere, your state HIE, right? So you have the technical infrastructures in place, and then often that will be, of course, covered by HIPAA or applicable state law, where you're sharing information for treatment and operations. And so, I think in that context, the rules of the road are well established, and I think health systems have a lot of familiarity with this. Where it becomes trickier is who are you hiring as vendors, either to do the analytics around the program, um, and I know we're going to talk about AI in a second. That's absolutely where it does become important that you always remain in compliance with your federal and state laws, that you have your HIPAA business associate agreement in place, and that you have the right data use restrictions in place as well. What I've seen often is some vendor may use the data beyond what they should be, or maybe in the agreement that allows them to use the data for purposes that may be broader than what was really intended. And so you need to keep a close eye on that data use and the restrictions, and is it really only being used for this purpose?
Sure, sure. And on that note, with from the hospital regulation side, we really see data becoming a question around the intersection of how it's used. And I'm just curious what you've seen or what you've managed, any real life experiences where you've seen it kind of go awry, or just any valuable anecdotes that could be helpful for.
I think we are, and I have spent a lot of my time working on this and promoting, right, interoperability. But we do unfortunately sort of see some circumstances where the vendor is not properly vetted, or maybe they have a downstream vendor that they use. And again, there hasn't been sufficient vetting that the use is going to be limited to what was agreed upon. And so it really is the sort of know your customer, but know your vendor, and know what systems they're using, and really scour that agreement to make sure that there's not some loophole, if you will, that allows someone to use data, whether it's identified data or de-identified data, in a way that the health system never intended. And unfortunately, we are seeing some cases where people, are using data in a way that they shouldn't, and the health system has to be very, very vigilant about that.
Absolutely. Utilizing it responsibly. That's what we
Right,
want
right.
to do.
And
Right.
and then on the other hand, you have information blocking, right? And so providers are sometimes in a difficult position, because if they don't release the data, they can be accused of information blocking under federal law. But if they release it inappropriately, then maybe they have some problems under HIPAA. So there's a balancing here again to make sure that the health system's doing the right thing by their patients.
You know what, Paul? That's a really important point as we talk about AI. So, what I'm interested to know is where do you feel, or how do you feel that AI intersects with team compliance, data governance, like in a concrete way? Like, how do you see the use of that coming into both of those fields and staying compliant, to your point?
Yeah, so I mean, obviously, we're all talking about AI. I think health systems, both large and small, are really embarking on this journey of what is the best governance of AI and the use of data. So I certainly see AI being used, in terms of teams again, because you need to do the analytics. You need to, wonder if you can use AI to better understand where your patients are going. I could certainly see a world where remote patient monitoring is going to become more important as well in terms of managing the care post discharge. And these applications and vendors are going to be using AI to supplement those capabilities. And so, I think the governance again becomes incredibly important in the tools that are being used. And I think systems that are successful have uh, have somewhat centralized that governance, right? I mean, you need your individual stakeholders to be involved. So if the radiologists want to use AI, radiology has to be involved, right? Population health, they need to be involved. But I do think that a system needs some centralized governance to make sure that all the AI applications they're using work seamlessly, and you're not developing a bunch of silos. So I think that centralized governance um, with um, with the involvement of the applicable stakeholders is key. But and then you just have all the issues again of the reliability of the AI, the accuracy of the AI. I still believe that in these early stages, you need that human in the loop concept to verify. But again, how do you balance that? Because if the human's always going to verify the data, you're not gaining the efficiencies that you want. But in these early stages, I think you need a lot of diligence to ensure you're getting the results from the AI that you really want. And then on the flip side, with data is to ensure that your data is not being used inappropriately to feed into the LLMs, to train the LLMs. It may be something that you want, but it gets down to again your agreements and what do they allow, because you just have increasing mobility of data in today's age.
Are there any questions top of mind that you would recommend a hospital system or before the centralization takes place? Like what questions should they proactively be asking before they ever set up the structure? Like is there anything that comes to mind like must asks before they adopt any kind of AI tool in this context?
Well, it always gets to obviously, your goals and maybe to some extent starting incrementally, I'd say, right? I think it's important also for health systems in order to gain momentum around the use of AI is to get some early wins. And so that again takes diligence. I think we've seen a sea change in just the past 6 months within health systems, with administrators, with clinicians who I would say a few months, certainly a year ago, there was a lot of skepticism. And now there's enormous enthusiasm on the use. We all use it in our personal lives and see some of the benefits, but we see some of the risks. And so I think you start incrementally, get some wins, do your due diligence, and start on the administrative side, move into the clinical side of the use of AI. But I think if you have to move deliberately, but we're also in an age where I think health systems do need to move with some speed because um, I do think AI will be very beneficial if it's used correctly.
Throughout our conversation, we've been touching on kind of the upstream and downstream impacts of the CMS mandate. I think that there's perhaps some questions being asked internally within the hospitals and even outside of the hospitals as to, is this really going to be enforced? And if so, how is it going to be enforced? I think some hospitals may be treating these penalties as hypothetical because there's just not a lot of information or intel that's being solidified since the mandate has come out. And you've lived through something similar in that at SureScripts with the e-prescribing mandates, right?
Yep. Yep.
And what's the historical parallel? What would you tell people?
Yeah, I mean, I think a couple things. One, I do believe this administration, based on everything they've said from the beginning, including the CMS Administrator Oz, that value-based programs moving towards value to keeping people healthy is a priority for this administration. So I think any programs they're putting in place that advances that definitely need to be taken seriously. But the parallel that I lived through with e-prescribing, goes back to the late, around the 2008, 2010 timeframe. And it wasn't just e-prescribing; it was meaningful use in the use of the EHRs, right, where the government put in place both incentives and then followed by penalties for the use of the EHRs, and then specifically for electronic prescribing. And we sort of had the same experience that people thought, well, maybe they'll never do it, they'll waive it, they won't really implement the penalties, and they did. They stayed true to the word and the regulation, and data shows it had an impact. There's no doubt that the adoption of the HRs and I think the adoption of e-prescribing increased because of those incentives, followed by the threat of penalties if you didn't meet the thresholds. So I think history would tell us that the government will be serious in implementing what they put in place with respect to that.
Agreed, agreed. That's valuable insight. History has a tendency of repeating itself, as we know. So, yes, definitely true.
Thinking about that, Paul, think about our listeners today. What would you tell them in the next 90 days? What would you say that their priorities should be as far as hospital compliance, legal from our conversation today? What would be your advice that they prioritize?
I think this is an important program. It's a mandatory program. It needs to be taken as such. And my advice is sort of where I started is you have to have everybody together, right, and working together, all of the various functions in the hospital to make this a success. And it'll be a success for your patients, and it'll be a success for the health system and providers, financially and clinically. And it's really, no pun intended, that teamwork, right, within the health system that I think is going to be key to success.
Absolutely. Any final closing comments? We're wrapping up on time, and we really appreciate you making the time for us today. Really want to offer any last closing remarks, any last words, again, anecdotes that could be helpful as we kind of continue on this first year of the 5-year mandate and what team is really going to be doing for the health system.
Yeah, no, I think it's an exciting time both for for Rainfall, but for the health systems that are implementing this. And I just wish everybody a lot of success because I do think it's an incredible program that is an important part in solving so many of the problems that we have been dealing with for decades.
Absolutely. Really valuable perspective from you today. And, thank you again for your time. For anyone that has any curiosity about team, please inquire. We like to be able to spread information and education on this topic. And, we really look forward to future discussions from anyone that is interested. So thank you all for watching. And Paul, thank you again for your time. It's been a
Thanks
pleasure.
for having me. Thanks.
Thanks, Paul.